All right, we're going to start the next session. This is the next series of the lightning talks. And I have my host here, Linda Bartlett, who's going to chair this session. We again have 4 terrific speakers. This session is addressing solutions as opposed to challenges, which were surfaced in the previous session. Linda is an MD, MHSC, with 30 years of experience in maternal and perinatal clinical public health practice. And she is currently a senior technical advisor to the UP-TSU program at the University of Manitoba. We are doing shorter bios now. Linda, over to you.
Okay. Hi, everybody. Late afternoon session, and 4 o'clock is when jet lag hits me hardest, so hopefully I'll be coherent. So I did want to make one observation. It's been an incredibly interesting and impressive day, and I'm getting to know India as a place to work and love it so far. But I was thinking about with these challenges in implementation that we've talked about, that there are about 26 million births per year in the country, and that's about 75,000 births per day. And apparently in the past 10 years, facility delivery rate has increased by 50%, from 40 to 80%. So that's a lot of births in facilities, and I'm wondering, has the infrastructure kept up with that? We don't have to answer that now, but it's just something that I've been thinking about. Yeah. So, okay, so I'd like to first introduce Rob Janett. Rob is a doctor, and he's the senior policy advisor and previous medical director at the Mount Auburn Cambridge Independent Practice Association. He still practices actively as a primary care physician, consults on health policy issues for the World Bank and other agencies, and also teaches at Harvard Medical School.
No slides. Oh, no. No slides. So no slides. If I had a slide, I'd begin with a cartoon. And it would have a bunch of IT specialists sitting around a conference table, and the caption would be, we have a lot of information systems, we just have no information. And so I have a confession to make. As you heard, I'm a primary care doctor, so I'm not a specialist in maternal and child health. I'm actually an internist by training. But comprehensive primary care is what I do best. And as we heard from Vishwajit, who has gray hair from his work in UP, from my work in global health, I have no hair, mostly below my chin, and that's where the gray hair is. So I work for Aceso Global, and my colleague and founder of Aceso Global, Jerry LaForgia, sends his regrets, but he wishes he could be here with you. So what I have today in 5 minutes is a couple of audacious proposals. And the question really is, how do we take all the wonderful work that we've heard about today so far and bring it to scale? How do we take the gleanings, the learnings from small or medium scale projects and bring them up so that they're big enough so that they can actually impact the population of India? It's an enormous country with enormous challenges. So we have as our objective a proposal to provide a platform that can provide incentives and provide the place where we can sort of develop these innovative models for organization and delivery of care and innovative projects to improve quality, and discuss them and bring them to scale. Now, I come from the United States. In the year 2000, the Institute of Medicine published a seminal book, To Err is Human, and it talked about the deficits in healthcare quality in the United States. It talked about the number of deaths that occur at the hands of the healthcare system in the United States. This publication provoked an enormous national dialogue. And it was followed a year later by another publication, Crossing the Quality Chasm, which explained the 6 domains of quality. By that I mean safety, patient-centeredness, timeliness, and the 3 E's, effectiveness, efficiency, and equity. And it also described the 4 levels of organization in which we address quality: the microsystem that delivers care, the organizations in which those microsystems are situated, patient experience of care, and then finally the educational, regulatory, legal environment in which care takes place. And so these 2 publications profoundly changed the way people in my country think about care, provide care, get evaluated, get paid. And quality is really on the top of the list of everybody's agenda. That's not to say that we have outstanding quality. We don't. We have a long way to go. But we certainly are addressing it constantly. And you know what? It's time for that same revolution to take place in lower and middle income countries. We would like to see the same type of dialogue go on, the same type of regulatory work go on that did for parts of Europe, for the United States, and some other countries, what it has done. Now, there's some work going on internationally. There's the Lancet Commission. The WHO has its global learning labs. We want to propose regional learning labs. Quality labs regionally that collaborate and create a national dialogue with standards of care, with standard measures, with highlighting the gems that have already been identified, and making sure that studies, which until now really have been micro-studies, the exception being the ones we've been hearing about this morning at significant scale, but most of them have been micro-studies or studies done in large tertiary medical centers which don't represent the care that is given to most Indians. And so we'd like to see sort of more population-based work going on. Where does most of this innovation originate? It's local. It's local. It's at the state level, at the local level, and at the micro level. And so we have to take these gleanings from micro models and expand them. We've done this. I'm from the People's Republic of Massachusetts. We achieved universal health care long before there was such a thing as Obamacare, the Affordable Care Act. Well, Obama took the learnings from Massachusetts and created the Affordable Care Act. That's what we should be doing here. In Brazil, where I've done a lot of work, a small group in the small northeastern state, very poor area, Ceará, produced the family health strategy, which became the basis for the entire public health system in the country. And you know, you may or may not know it, but RSBY really began as a series of state, government-sponsored health insurance schemes. So it happens here too. The point is, this is a federal country. Healthcare is federal, but leading from the top is a weak strategy. We know that leading from the top creates very little change. And so we're proposing laboratories in which we can essentially lead from the bottom up. So what do we want to fund with these laboratories? We want to establish a fund that will receive proposals to do largely 2 things. One is new approaches to the organization and delivery of care, knowing full well that the private sector, which delivers a lot of the care in this country, is tremendously fragmented, and we have to think about ways that some of these private providers can aggregate. And we have to make sure that these pilots, these programs, have private participation and public participation. Secondly, you can't improve what you can't measure. We've been talking about this extensively. We really need laboratories on measurement so that we can get real and be standard about ways in which we approach the issue of measurement and learn from one another so that what we learn in one state can be expanded to others. Finally, we want to make sure that we can think about integrating hospitals and community and break down some of the silos that are evident in this country between care delivered in facilities and care delivered in the community. And so a vertical integration series of demonstrations would be something that we'd propose for this fund. The second audacious proposal, again for 1 minute. The second audacious proposal is to form a National Quality Information and Improvement Commission to hold all of us accountable for this kind of quality work. You know, we have to figure out how to get beyond this cultural concept that quality measurement is punitive and is going to be used against us, and instead really think about the true sense of quality improvement. Through this fund, we can begin the process of dialogue and incentives to start bringing this to fruition at the regional and then ultimately at the national level. Thank you.
Well, I don't really have to introduce Dilys, but I will. She's a professor of obstetrics and gynecology and director of the Global Maternal Newborn Health Research Cooperative at UCSF and co-founder of Pronto International.
Thank you. No slides for me either. So I'm going to go micro, get away from the macro, and share with you a quote. And this is what keeps me up at night. These women are suppressed so much that they say they cannot speak loudly. Their voices are so low. This quote came to us just last week from a master trainer at the first day of a recent care nurse mentor training in Bihar. One of the aims of this new nurse mentor training program, sort of the next generation for sustainability, is that the idea that former mentee nurses are going to be transformed themselves into mentors. So this is our current challenge. Can former nurse mentees find their voice to now become mentors themselves? So it's really great to have the opportunity to share with you a little glimpse into how we're addressing this very difficult question now. Dominique presented this morning this idea of a new framework for looking at quality of care, and our contribution, and that is integrating, that's the key word here, highly realistic simulation and team training into the care Amanat mentoring programs, has focused primarily on supporting those boxes on the right. Okay, so we're talking about modifying motivation, capacity, skills, knowledge, clinical best practice, and person-centered care. So these all require behavior change, not only of the individual, but of that system in which all of those people are working. So consensus is beginning to build that we can't pick out and address each of those individually, and we've been talking about this today. So I just want to share with you a little bit about how we do that, how we do avoid picking this all apart through this simulation and team training. So we actually embrace that local complexity. It's the team themselves that identify how each of these process components exert influence on the other in a unique way, and how might that curve towards improved care might be moved in that particular setting. So over the past 3 years, we armed the Amanat mentors with the skills and ongoing support to conduct, and I want to emphasize more importantly, facilitate emergency simulation and team training and communication as a component of that program. And perhaps kind of unintentionally, but I'm beginning to believe maybe at its core, it's our training that helps mentors and nurses find their voice. And if a provider and a mentor doesn't have a voice they can use, how will they ever manage an emergency successfully? So the human to human, and this is what Vishrajit was talking about, element, may just be more important than the skills and behaviors that participants learn and practice. Through simulation, they practice. So we dive into this practice and practice how the different people interact. Providers, nurses with patients, nurses with nurses, nurses with doctors, and family members and MUMTAs and all of that complexity. And probably, more importantly, what we keep feeding back to is the relationship between the mentor and the mentee. So if India is going to continue to invest in mentorship through Dakshata and other, what we're hearing today, mentorship is all the rage, we need to understand how these relationships are important and how they influence one another, and particularly that where that mentor-provider role fits in. And these are often, I think, overlooked pathways. So the CARE mentoring program included 31 simulations, 14 communications, 120 mentors, video recorded over 11,000 simulations across all of the facilities. Each facility received almost 20 scenarios. We coded those simulation scenarios and the debriefing facilitation for quality improvement on practice, behavior, and patient-centered care indicators. And I can easily go into more of what we learned on that. So just very briefly, another mentor wrote us last week through WhatsApp. Again, WhatsApp is a big key here. Speaking up, sharing their thoughts, organizing groups is something they have never done and never been encouraged to do. It's a big leap to ask them to facilitate. It was also a big leap to get them communicating as clinical mentor, as a clinical team during Amanat. We managed to do that, and now we're moving to see if we can meet this new challenge. We used to think it was just knowledge. Then we learned enough to realize it was knowledge and skills to drive quality behavior. And I think we all have to embrace that on top of the knowledge and skills, we need to address communication and teamwork. Thank you.
Thank you, Dilys. Next, we have Abhishek Gopalka. He is a principal in the social impact and public sector practice of the Boston Consulting Group in India, focusing on social outcomes, and is currently working with the government of Rajasthan to improve primary care.
So while the document's coming up, I am not a doctor, I am not a professor, I am a management consultant, and therefore I do use PowerPoint. But you know, all kidding aside, there's been a lot of conversation today about systems, about a systems approach, and about data. And the question that I'm really trying to ask ourselves is, how do we get government to start using data? How do we build systems to enable government to start using data to improve quality of care? Very provocative, sounds like a mirage. Let's explore. Just in terms of context, we're working with the government of Rajasthan, not just in health, but in ICTS as well. And the whole idea is, how do you improve outcomes? How do you improve health outcomes? How do you improve nutrition outcomes? And how do you do so at scale? And how do you do it sustainably? The one important point out here is, it's a very small and nimble team. It's really meant to be working with the government, improving their systems, because long after BCG is gone, we want those changes to remain. So what are the drivers of low health outcomes? I'm not going to describe that to this audience. I mean, everyone knows what the major drivers are. But just conceptually, the way we'd like to think about it is in 3 segments. Number 1 is context. Again, we've talked a lot about the context today. So changing the orientation, moving the questions away from inputs, is the building in place, have people been trained towards outcomes, and really sweating about that and having a sense of urgency about it. Second is the whole inputs. I'm not going to deny that there are input gaps in the country. The question is, how can we manage the inputs smartly to get more out of less? And third is the accountability crisis. How do we drive performance from these inputs? Once you've set the context, once you have the inputs in place, how do you drive better performance? So 5 ideas. First one is around an outcome-oriented culture. I completely agree with the point that it needs to be both top-down and bottom-up. But in a country like ours, the leaders set the tone. Whether it's a health minister or a health secretary, they simply have to ask the right questions, and those questions need to be about outcomes. Number 2, more out of less. I mentioned I'm a consultant. You can't take a consultant away from 80-20 for too long. We absolutely do have resource gaps in our country, but we'd like to argue that you can get much more from what we currently have, whether it's people, whether it's budgets, whether it's infrastructure. And how can you use data to be able to do that? Number 3 is one view of the beneficiary. And I'm not just talking continuum of care out here. I'm talking about a vicious cycle which certain families get into, where you escape mortality, but you still have a morbidity issue. And how do you track beneficiaries not just along the continuum of care, but over lifetimes? Number 4 is around facility-specific enablement, not a one-size-fits-all approach, where carte blanche, you're trying to do training programs across the board for a innumerable number of facilities with very limited training resources. How do you make it much more facility-specific? And number 5, how do you do micro reviews and how do you make them actionable? It's not just about the ideas and insights. It's going to be about what do I do with those insights starting tomorrow morning. So the first one, an outcome-oriented culture. In Rajasthan, we have a secretary who's actually instituted a program called Project Chirayu. This is the Hindi word for a long life, to reduce neonatal mortality. And she's asking questions like this one, which says, this was a meeting in the end of January, where we flashed this picture and said, these are the expected number of neonatal deaths that we expect in the 8 districts, unfortunately, in the month of February. And there were 10 officers sitting in that room, and we said, these are the folks who have the power to reduce that number. So what are we going to do about it? And the question we're asking ourselves is this too soft? Do we need to put pictures behind these numbers? Do we need to put stories behind these numbers? How do we make it real? How do we instill a sense of urgency? Number 2, more out of less. You need our FRUs within 2 hours driving distance. Can you not use your friend Google to talk about 2 hours driving distance and how many facilities do you really need? Do you need 35 in 8 districts? Can you do with 25? Something to think about. And it's not just about fixing them one time. There has to be mechanisms to be able to identify where the gaps are on an ongoing basis and being able to fix them. So we've created a mobile app which block officers and district officers use during their visits, identifying gaps, and the whole idea is to now issue tickets, which they will then close to maintain the system. We talked about building one view of the beneficiary over time. We're living in a world where, forget about integrating the MIS systems of health and ICDS. Even within health, there are 15 MIS systems. For those of you who are, well versed with the information systems that we were talking about it. So integrating all those health MISs and integrating the ICDS system and integrating both of them to be able to generate proactive actions to get people out of this vicious cycle of morbidity and mortality. And don't forget to validate the data. This is the data from one Anganwadi center where we're looking at growth monitoring data for 24 children, month on month. Miraculously, 23 out of these 24 children, their weight increased by precisely 100 grams every month for the last 3 months. There is a culture of fear. This is garbage in, and there will be garbage out. And you've got to make sure that the data is valid. Fourth, facility-specific enablement. We talked about the fact that training resources are limited. So how do we make the most out of them? The regular mechanism of being able to identify where the training lacuna lie is that really using in-person assessments. But how many mentors are we going to send? And how often are we going to send them? can we use outcome metrics instead to identify where the issues lie? So if you look at this slide, the red and the green dots are the result of in-person mentor visits to assess the level of outcomes. The red ones are the ones which require interventions, the green ones don't. But if you look at the outcome metrics, which is the asphyxia cases in the SNCU, it's actually a very strong correlation. So you wouldn't have been too far off, saved your dollars, and actually looked at the outcome metrics to say what facilities need what kind of help. And the last idea, micro reviews. I'm going to flip through the slides very quickly to say, these are reviews of every kind of facility, SNCUs, LRs at every level, and talking about metrics as granular as referral rates, LAMA, and institutionalizing these reviews. And the last point around integrated MIS and the data which will inform the prioritization. Every district needs a plan. All districts aren't the same, but can we bucket them into archetypes? We're using a framework where we're saying, look at the use of antenatal corticosteroids in labor rooms. And there are districts which are not using them much, and they need to use it much more because the deaths due to RDS is much higher in those districts. But there are some which are actually using them, and they're still looking at deaths. And so the clinical practices need to improve in terms of when those antenatal corticosteroids are administered. And that just gives you a framework for how do you approach the system. So go ahead, use data. Thank you.
Great, thank you. Now we have Manoj Mohanan. He's at the Global Health Institute at Duke University. And his current research projects include development of innovative methods to measure quality of care in primary care and also program evaluations.
Thank you. This is what I get for not sending in my bio on time. You actually have my old institutional affiliation. So I should probably start with saying I'm at the Public Policy School and not that who actually pays my salary and not the Global Health Institute. But anyway, this is the problem when you are an academic coming in after a management consultant. You have really boring slides. I should have actually come in with at least Beamer slides, so I'll have some credibility at least, but now I have really bad PowerPoint slides, so bear with me. So what I'm going to try to do. Yes, but Beamer slides are at least slightly prettier than PowerPoint. But anyway, what I'm going to try to accomplish is almost impossible. I want to tell you about two things because the topic here was think about how you can solve some of the challenges we talked about today. And I want to tell you about two solutions. Usually I take about an hour and a half to go over each one, and I have 5 minutes to cover roughly about 2.5 hours of material. So let me jump right in. So this first one is a project that we had done in Karnataka around the time when the state of Karnataka was trying to do contracting agreements with the private sector. And so working with Kultar's team, we ran a large experiment where the central idea was the following. We wanted to ask two questions. One is, if you're going to do incentive contracts, what's the best way to do it? And yes, we heard this morning that incentive contracts work, don't work, mixed evidence. But there was someone mentioned it's a blunt tool, and that's exactly the problem. If you look around the world, everyone's trying different types of incentive contracts, but there's very little attention to the details about the structure of the contracts. So we want to understand what type of contracting works, and more importantly, for whom? The human element question that came up. So we want to ask under what circumstances, under what types of people, how does this work better? So I'll skip much of this and, oh wait, where's my nice slide on? Let me start with one quick point of disagreement. Not so much disagreement, maybe it's a different way of looking at it. At some point we talked about, healthcare providers are in their particular positions, they are already doing the best they can. I disagree. I think we know from a lot of empirical evidence that healthcare providers are doing systematically less than what they can do and what they know how to do, whether it's about antibiotic prescriptions, whether it's about treating patients or diagnosing cases or even treating patients well. In all of these conditions, there is this question of effort. Effort is costly, and so the question really is how do you make it optimal for healthcare providers to invest a little more effort so that you can align the objectives of the providers and that of the principal in this case. So what we are trying to do here is we ran this experiment where essentially we had 3 groups, where one group was told, Doc, you're the expert, you know best what to do, as long as you can show us the results. That is, you show us reductions in PPH, sepsis, neonatal mortality, and preeclampsia, we'll give you a fat sum of money. Fat sum of money in this case was almost about 1.5 lakh rupees that they could get at the end of the year, which is not trivial. And to the input-based providers, we said, doc, you're the doc, you've been to medical school, you've seen all of this, but by the way, here are the current Government of India and WHO guidelines. If you demonstrate better adherence to this, you can get a lot of money. If 100% of your patients get perfect care as per WHO guidelines, you can get the same amount of money. Contract providers, we told them, you're the doc, here's the reminder about what was supposed to be done. We are doing a study in your area. Thanks for participating. We'll just be collecting a lot of data from your patients and stuff. This took a long time, starting in 2012, where we started the visits, and Kultar's team managed to find these doctors, and we did the contract visits with the government. This was, by the way, a collaboration between World Bank, government, and us, so it's not your tiny little lab experiment. And then eventually the data collection at the end of the experiment was in end of 2014. And like any self-respecting econ paper, this has been under review for 1.5 years. So wait for another 1.5 years before it gets published. Okay, so the two things, actually, this, since it came up earlier in presentations as well, I do want to say, in health system types of studies, clustering standard errors is super important. And in our case, in addition to that, because we have 4 outputs, 5 types of indices, and 2 treatment arms, doing multiple outcome corrections is super important. Otherwise, everything looks statistically significant and might not be meaningful. So here's the main result. What we find mainly is that both input and output-based contracts reduce postpartum hemorrhage by about roughly 20%, which is pretty large. But we don't see much of an effect in terms of on the effects on preeclampsia, sepsis, or neonatal death. And those stars you see there are after doing the family-wise p-values for doing multiple outcomes corrections and whatnot. So these are fairly significant large reductions relative to the control group. One might ask how, and what we find in general is that both of the treatment groups use more of the oxytocic drugs. I know Sridhar was telling us that might not be a good thing, but the point is these contracts were written based on literature from 2009-10. At that time, it was still considered good practice. And a bizarre thing was when we did this, massaging abdomen was considered to be a good thing and then subsequently not. So we find that the input-based guys are the ones who are doing it and output are not, so which I guess is a good thing. I'll skip over another thing here just to tell you the key part here. What we find is providers with high levels of human capital, and this is exactly what contract theory would predict, is if you tell somebody who's highly trained that you need to achieve a target, they'll do that using innovative strategies. Versus a low-level trained provider, if you offer them output contracts that allow for creativity, you might not find as much. You'll find them just doing more of the same. And that's exactly what we find, is that most of the maximum improvements in the output groups come about in the group that has MBBS plus. These are the MD and other providers. And we also find that they innovate a lot. So this is the effect of output contracts on innovation. So quick takeaway from there is, yes, different types of providers are going to respond. If you just go in with an incentive contract, you might be sadly disappointed. So we need to think about who reacts how. We also had another paper in the American Economic Review where we looked at the types of providers. Again, here, for those of you interested in personality, providers who are conscientious, like the do-gooders, you do find evidence that incentives actually take away some of that effect. So the conscientiousness doesn't work. And people who get very nervous in these settings also don't work. I think I'm out of time. I'll stop with one sentence about the project I didn't tell you about. So in UP, we are right now doing this large community monitoring study. You probably know of the Uganda results there. They found massive, miraculous 30% reduction in under 5 mortality. We are testing it out in UP, again, in a large cluster randomized experiment. Data is still coming in. Hold on to your seats. Maybe in about 3 weeks, I'll tell you what happened. So.
Okay, I think we're keeping on time. Our last speaker is Hemant Shah, who is Chief of Party for the Bihar Technical Support Unit and has worked in maternal health for 20 years, I believe it says.
Good evening. After management consultant and academician, I'm a medical doctor who become manager and now keep an eye on a burn rate of a grant. So I've decided as a last presenter not to use a PowerPoint presentation, neither use a data. I'll share a few anecdotes, few stories in a very brief. In the first week of March, I was in a meeting with the Principal Secretary of Health in the state of Bihar, and the 4 nurses came with their grievances. The grievance was that they haven't got salary since last 11 months. All these nurses are working in sick newborn care unit. As a part of system strengthening effort, the special cadre was created of the doctors and nurses who are dedicated to work into the SNCUs. When the budget was prepared, the guy who was preparing a budget forgot to just add a salary of the staff into the budget held allocated for that particular cadre. The net result was that the nurses and doctors, both were working in the SNCUs since 11 months, were not getting salaries. My colleague shared about incentives. Just last week, I was in one of the subdivisional hospital, and we were discussing about the cesarean section rate. And naturally, the incentive should be linked with the performance, and it should not be linked without performance. So the government of Bihar decided that for first 5 cesarean section, there will be no incentives, and the incentives will be paid only after from the 6th cesarean section. And the doctors, there were like 3 lady doctors who were working in that facilities. The argument, who will conduct those first 5 cesarean section? Because from 6 I can get incentives. The third brief story. Whenever I visit to any SNCU, I see almost 40% of newborn baby having a basically symptoms of birth asphyxia. So it's extension of birth. Healthy baby, 2.5, 3 kg, hypoxic encephalopathy. And when we look into it, it's a win-win situation for everyone. We are on one side struggling of oxytocin usage at appropriate time, but on the other side, the ASHA workers who bring women from home to the facility gives oxytocin intramuscular at home to make sure that the woman delivers in the facility in the time. When the shift timing changes, the nurse who have paid attention to that particular woman for a few hours, if woman will not deliver in her duty and the woman will deliver in some other nurse duty, she will miss the additional incentive which she is going to get from the family. And for family, when they come to the facility, because referral transport system is completely broken, so they use some vehicle to reach to that particular facility, they are also interested to go back home in the same vehicle so they don't have to pay twice. So essentially, it's a win-win situation where oxytocin misuse might be a great problem for all of us sitting here, but it's not a big problem for the family, neither facility provider or the motivator. The fourth brief story, the oxytocin, when we were working with the government in Bihar, we pushed that the storage should be maintained, it should be refrigerated, and without that it loses the potency. And what happened net results? The government of Bihar, when pushed back to the manufacturer who were providing oxytocin, they said, we haven't budgeted the cost of this into when we agreed for a rate contract, so we are not going to supply you. The net result was supply of oxytocin stopped. And the story goes on from a corporation point of view, like to making sure that the supplies are sustainable and there is a system in a place. So Bihar government decided on the line of the Tamil Nadu Medical Supply Corporation to establish a Bihar Medical Supply Corporation. And we have to innovate. So in spite of drug and equipment, what we added as a corporation, infrastructure wing into it to make it more complex. And as Dr. Khandayat rightly pointed out, we copy pasted everything from a corporation point of view, But what we haven't copy-pasted is the necessary ingredient of having right kind of a procurement manual in a place, right kind of a processes in a place, right kind of IT system in a place. And after a couple of years, what happened, there was a scam in the corporation. And we failed to procure medicines in a decentralized way. Now we failed to procure in a centralized way. And finally, the out-of-pocket expenditures went up. I would like to share about data. Of course, Rakhi rightly pointed out data should be central to the quality of care, but for whom? So we tried with this case sheet, and a case sheet not in a traditional bedhead tickets point, or not with the traditional checklist point of view. We decided to merge the bedhead ticket idea with the checklist to make sure that this case sheets in a way help to take a right decision by the service provider on the ground. But what we observe, in spite of that, it was a tool which would ideally should help them. Most of the time, the nurses were filling those checklists post facto, which was a case sheet, not a checklist in a way, right? And when we try to understand that, it's only one nurse who will be there to take care of few deliveries at any given point of time, and you are expecting her to fill a case sheet, not a post facto, but in a time, which is not going to happen because someone is supervising. So that's why it is important for her to fill that case sheet, so the data can be punched in the system and data can go up. So I think more important question is, are we collecting data for sending data up or actual for usage? And the last point just I want to make here is in the state of Bihar in 2005-06, there were 39 patients were visiting a block primary health center per month in outpatient. Nowadays, 11,000 patients per month visit in outpatients. But during those days, not a single hospital was burnt, not a single doctor and nurses were beaten up by a mob, and now every few months we listen a story that something went wrong and the mob attacked the hospital, burnt the hospital, beaten the doctor. We discussed in the first session about respectful maternity care and respect to the client. I think there is also need to seriously think about respect to the service provider. Thank you very much.
All right, well, it's a tough job to try and summarize some of those key points, but some of the things we touched on in this session and also today in general was how India is, as we just noticed, a very large population. It's also very diverse. I think it's actually the most diverse country that I've ever worked in, where you have parts of the country where they're as traditional as the families that I've worked with in Afghanistan, and yet highly sophisticated populations as well, which makes it interesting but also makes it challenging. So there's the scale. There's also issues of gender, which I'm glad that Dilys brought up. I think that is very important, both from the side of the patient, the woman who's in labor, but also a largely female provider population at the front lines, and their empowerment and also their security in rural areas. We've talked about a lot of complex solutions, and I think because the challenges are so complex, the solutions also have to be relatively complex. Yet, what we've also talked about over and over is the dyad of the mother and the provider and what's happening between them. And so keeping our eyes on that target of mother-client or provider-client may help us to streamline or focus the solutions. And the solutions also have to be simple enough to be feasible for implementation. So let's keep that in mind as well, and flexible enough for the changing times.
I would like to congratulate the organizers. So many good things have been said, but I'd like to highlight 3 themes that have been touched upon but could be added. Why am I saying this? It's late in the day, very late on the clock. It's late for me too. I stepped into a delivery unit as a young doctor 46 years ago, and I've been spent my time on maternal newborn health since then. So it's quite a while. So what did I learn from working in low-income countries and high-income countries? Most recently, I worked in Cambodia. That happened to meet MDG 4, 5, and 6. Not so common. What are the themes that have come up today that I would like to expand upon, just very, very briefly? First, we touched upon it this morning. What's the most important and cost-effective piece of technology that you can put in a delivery room? It's a person with midwifery skills. We have known this for 150 years. I can give you the publications from a country that introduced midwifery training, 2 years of training in 1860, 150 years ago, a time where there was no blood transfusion, no antibiotics, no C-sections, and in 30 years, they brought down maternal mortality from 720 to 220, which happens to be the maternal mortality rates in UP and Bihar today. Took 30 years, but it took midwifery. What can you not do when you add blood, antibiotics, doctors, C-sections, many other things? India is just now, the Ministry of Health is since a year back asking the Gates Foundation and other partners for help in establishing midwifery. Let's speed it up. Let's get going and help India. Because you may not want to go down the route of Brazil. You may not want to go down the route of one high-income country that I will not mention that has a rising maternal mortality, the country I happen to live in. Look at the Lancet issue on midwifery from July 2014 and look at the facts. And let's get on with, you don't need to call her a midwife, call her a nurse with specialization in midwifery, but make sure she has the midwifery skills. That's where part of the gold is. Second theme, Sridhar mentioned this morning that the next step, and I'm really trying to look at the 5 to 10 year perspective. You are doing so many encouraging things, and the decline in newborn mortality that we think we can see in Bihar is so inspiring, but let's look a little bit longer than this year and next year. Sridhar mentioned that they were now thinking, that CARE was thinking, Hemant and others in Bihar, of how to have mentors, nurse mentors at the district hospital, and doctors who are mentors at the district hospital. So let's just add to that, how can you expand from looking at facility by facility? How can you look at the quality of care in a sector, meaning under a CEMONC hospital, and how can a few leading staff, these nurse doctors, mentors, or any other interested clinicians in the CEMONC level hospital look after the PHCs and CHCs in their catchment area? That has been called vertical integration, and Rob mentioned that. Vertical integration has a bad ring in it because it reminds us of vertical programs. This is really not vertical integration. You could call it district level integration. But how can you get that connection? Please don't come and say referral systems and think only of transporting Mrs. X from a PHC to a hospital. How do we get the transport on the phone? That's not, for me, a referral system. A referral system is where you have a team of people in a health facility who interact on a regular basis with the people at the referral hospital. Regular basis, meaning you get together at least every 3 months and sit down for half a day and discuss your most recent cases. And that's where you can discuss, well, how are we doing on PPH, dear friends? How many PPH cases have you done the last 3 months since we last met, and how's it going? Did they survive? What did you do? How many breech deliveries did you have? That's the kind of data we have to have to avoid the mailbox syndrome of putting things into 18 registers and mailing it to the Ministry of Health and getting something back 3 years later if we can bribe somebody in the Ministry of Health when we happen to visit the capital and get a photocopy of the page that pertains to us. It's using the data here and now in those monthly or 3 monthly meetings to improve the care that we have. The main consumers of the HMIS data is us here in our little unit, in our team. And our team is not only our facility. We are striving for the results in our catchment area of this CEMONC hospital. So that kind of teamwork, we can expand on that. But that's my second theme. And the third theme is actually quite different. And the third theme that I'd like to flag here is that let's just remind ourselves that maternal, newborn, and actually also childcare is not primarily about care of the sick. It's the care of the well-being. It's the normal labor, normal pregnancy, normal birth, normal parenthood, normal motherhood. That's what we're speaking about. 85% of these women and babies, they don't need us. Problem is we don't know which are the ones that need us. So we are inviting them to our facilities, and people are coming at an unprecedented rate. The ecosystem of human birth has changed in the last 20 years, from mainly home births in many countries to mainly facility births. So it's actually our responsibility, and we have much more higher ethical responsibility today than we had 20 years ago. If we only deal with fractured legs, with cancer and appendicitis, well, you come to our hospitals, we'll operate you, right? But these women are coming with a life process, isn't it? Where it's our responsibility to do more good than harm. And to do that, we need to listen to women's voices more. There was a movement here when the new government came in. What do women want? The new digital transformation provides us with new opportunities to listen to women's voices and to communities. There are various types of digital devices where women can learn more about normal pregnancy care and can be better advised for not only getting maternal, but newborn, child, and family planning care, hearing the options through various devices and methods from edutainment to smartphones for my individual care. But you can also listen more to women as groups, and you have a big movement of self-help groups in this country. There are other ways of really capitalizing. Let me speak of Kenya, where fistula survivors constitute the new safe motherhood movement in the country, where women as groups turn from being passive patients to informed and activated clients that can inform their own care and actually also influence maternal care as a whole. I spent my whole professional life as a maternal health person, an obstetrician turned public health. I personally think that maternal health care is much too important to only hand over the responsibility to managers and politicians and doctors and obstetricians. You have to listen more to women. We need to find more ways of strengthening women's agency. And the digital revolution helps us to do so. So that's my third theme. We have to be very thoughtful because we are in a big hurry. Thank you.
So that couldn't have been a more inspiring way to sort of tie the bow on today's conversations. Thank you so much, Jakob.